go. This one's on continuous care documentation. So we have gigantic documentation notes. We're going to go over them. So basically the concept is you're going to complete all of the fields, including the patient's name, medical record number, your name, the date, the day, the total number of hours you worked, time in, time out, the patient or the caregiver, someone other than an Illume employee needs to sign to certify that you were there, and then your signature and title. This certifies everything in the document. All the pages is accurate, including the times in, times out. So the initial assessment, you're going to go through each one of these things and see if it applies. Some things we really should do, including checking the go bag, individualized emergency plan, all the items here, the precautions, if the person has a trach or a G-tube, etc. So this is pretty self-explanatory. This particular line, the last day that the DME was checked, should be the day of your visit because you should check it at every visit. So this date should be the same as this date. Neurologic assessment, again, you're going to document what applies to that person. Same thing with cardiovascular, as much as you can. We really should be covering and looking at all of these things as part of our, general assessment for the patient. So you should be able to answer all of these. Respiratory is the focus of a lot of our patients, so pay particular attention to this area. You'll note in breath sounds, I check 2 boxes, so what does that mean exactly? So I try to clarify that, clear in the upper lobes, diminished in the bases. And then productive cough, well, and this is what I have, and that's a description of it. It's also in this next section. It's a little bit redundant, but again, I want it to be clear. A little bit more detailed information respiratory-wise. Now we're going to move to gastrointestinal. If you have a weight, I happen to have one for the purposes of this. And depending upon the person, their age, you may want to be documenting in kilograms or in pounds, depending upon what the situation is. Often meds or, enteral feeding is based on the weight. So if it's required that you get a weight, however frequent, daily, weekly, whatever it is, make sure you try to do it the date that you acquired it. Bowel sounds, what they are and where they are. Last bowel movement, what it looks like. The person is only on enteral feeding, they're going to be NPO. Otherwise, sometimes people are a mixture, sometimes they're just oral. And so you try to put the information that you can with respect to that. And then documenting on the G-tube site. A lot of our patients have G-tubes, so again, you want to be clear. Ear, nose, throat, and mouth, you're going to document when it's applicable. In this particular case, the person doesn't have any hearing issues, so I wrote not applicable, ears within normal limits. So no infections, no drainage. For throat, well, they don't have any of these things that have a box next to them, but they do have a trach, and that is in the throat. So I wrote that in. Teeth present, yes. What the oral hygiene is, what it is that you're doing. If the eyes are reactive, and I put down what they were, 4 millimeters bilaterally, etc. So that's pretty self-explanatory. Musculoskeletal, you're going to just go through this. This particular patient has limited range of motion to their lower extremities bilaterally, so I wrote that in. They're flaccid in terms of muscle tone. They are a Hoyer lift. Passive range of motion exercises are to be done, and they're repositioned every 2 hours, their total assistance. The bottom part, you're going to print your name, Nancy Nurse in this case, sign Nancy Nurse, and that at the end, your report was given to Kim Caregiver, LPN. Moving along to the second page of our continuous care note. Again, you're going to put the patient's name, medical record number, and the date. You're going to address pain. Pain is the 5th vital sign. It needs to be addressed at every shift. So you're going to say whether or not the person has pain and where that pain is, if you can determine it. In this case, this patient has a history of having muscle spasms in the lower extremities on both sides. So this is what we've written. Use this scale, the FACES scale, to determine how many out of 10 approximately. This particular patient was repositioned and given medication with a good outcome. Skin, really need to document skin at every visit. If the person has no wounds, we want to make sure that that's clear. If the person does have a wound, you need to follow these and really determine if it's a pressure ulcer, what stage it is, where it is, etc. But in this case, for purposes of our example, there were no wounds. This person also does not have an IV. There's no IV access, so there's a box, not applicable. Check that. You're good to go. I would like to ask people not to put a line through it diagonally and not to leave it blank. Each square needs to be addressed. If you needed to call the physician, you would need to write here that you notified the physician and the time, who you spoke with. As y'all know, sometimes we don't get the doctor, sometimes we get the doctor on call, sometimes we get the medical assistant, that person's name, if any orders were received, and if supplemental orders were written, and who was notified. If the supervisor was notified that you got orders, you called the physician, etc. That needs to be written here. Education, this is a very frequently left blank field. This is really important. We're supposed to do education every time we come in one way or another. It may be reinforcement of education, it may be a new education. In this particular case, we reviewed hand washing and disease process with the patient's mother, standard precautions specifically in hand washing. And then we also went over Tylenol, and we discussed with the patient's mother how the importance of medicating the patient at the onset of pain and not to exceed the daily milligram limit for that particular medication. So we went over the action of it. We had the mom demonstrate hand washing and repeat back some of the information which she was able to do. She had a good understanding. Verbal and return demonstration were the evaluation methods. Does she need further teaching? No, it was really a review. She knew this, but as part of our ongoing education with the family, we want to make sure they don't lose sight of some of the things, particularly if they start to get lax on some of the hygiene, really important with respiratory patients. We reviewed standard precautions, medications, and procedures to follow up for medication treatment and adverse reactions. So GU, pretty self-explanatory. Again, you want to try to be as specific as you can. These things may not seem important if the person's not having symptoms, but if they are having symptoms, we might look back and see, well, when did this start? And if things are documented as normal, we have a good idea. So we're looking for trending and how their urine is handled, whether they're incontinent and what kind of method we're using, if they have a catheter of any kind, all that needs to be documented here. If the person has INO, there's a separate log for that. And then these are vital signs. Now, vital signs are generally once a shift or sometimes every 4 hours. In this particular case, the patient had an episode of pain, so there were the initial vital signs that were taken at the onset of shift. Then the patient had an episode of pain and restlessness, so vital signs were taken, and then vital signs were taken after that to confirm that in fact they had stabilized. It's a very small, slight change, but as you know, for some of our patients, it is like that for them. Sometimes it's the slightest change in vital sign or behavior that is important for us to note. This is a really important little tiny square. This is often left out. Goals addressed per care plan should be checked. You need to be following the plan of care, that should be checked. Discharge planning, even though these patients are long-term, it still needs to be checked. We are keeping them stable. We're alerting the supervisors to anything abnormal. If the person is no longer appropriate for the level of care they're at, then that needs to be addressed. So it's all connected. Everything we do every day relates to discharge planning, should always be checked. And now we start our narrative. So it does start on page 2 and it generally continues to page 3. There should be a notation at the beginning of the shift, received report from Helen Helper, LPN. No issues noted overnight, etc. So there's a little tiny review, what happened. In terms of your narrative and your documentation altogether, you're going to document toward the skilled need, very important. If everything is good all the time, why are they paying for us to be there, right? So we need to say what it is we do. Get credit for what it is you're doing. So we start, the enteral feeding was infusing, the patient had some suctioning, nothing is really abnormal, morning care is completed, including, and here's your skill, suctioning, trach care, incontinence care, oral care, and bathing. Again, print your name, sign your name, and report given to Kim Caregiver. That's who takes it at the end of your shift. Page 3, notice these aren't numbered the previous ones, but page 3 is 3 of 3. So every 2 hours is our standard. A little bit more frequently here because the patient had an issue with pain. If something comes up, you do want to write it down. So you begin, you did some site care, you documented a few things, you did some teaching with the mother. 9 o'clock is when the pain started. You documented that, what you gave, that the mother says that the patient has muscle spasms, and then you document the result. So you notify, you notice a problem, what you did about it, and what the result was. 1 o'clock, again, there was patient had a bowel movement, so you're going to document that. And also you did this passive range of motion. That's part of the care plan, so you want to make sure that you get credit for that as well. And then at 3 o'clock, a little bit of education with the mother, and then also that you gave report to the next nurse. I just want to bring your attention to this. If you do make a mistake, you want to draw a line through it so that that word can still be read. Write error and your initials. That is the standard for how to document a mistake. And then finally at the bottom is the nurse's name printed, the report who the nurse that report was given to, and then the signed signature of the nurse who did the shift. So that's it. Thank you so much. Any questions, let us know. If it's not clear, we can do another video. Yay! See you later. Bye.